Good afternoon, everyone, and welcome to today's webinar hosted by Region 8 chapters of HFMA. The topic for today's webinar is Creating Your Own Patient Financial Navigator Program. Every facility can do it. I'd like to welcome today's guest presenter, Egusquiza of AR Systems. Day is no stranger to HFMA. She brings over 30 years of experience in healthcare reimbursement, hospital business office operations, contracting, and compliance implementation. Additionally, her experience includes 8 years as a Director of Physician Medical Management Billing Service, which included completing an integrated business office between a hospital and a large physician clinic. Ms. Egusquiza is a nationally recognized speaker on continuous quality improvement, benchmarking, redesigning reimbursement systems, and implementing an operational focus of compliance both in hospitals and practices. She's been on the AHAM National Advisory Council, the HFMA National Advisory Council, and is past president of Idaho HFMA chapter. I've had the pleasure working with Day on countless webinars and in-person events. So without further delay, I'll hand the call over to today's guest presenter. Day, please go ahead.
Thank you. Well, good morning. Still morning. Great. I'm trying to keep track of time zones. Good morning. It's wonderful to be with you today and share this really kind of cool webinar with you. I also, by the way, hope to get to see a whole bunch of you at Region 8's meeting in Kansas in August. I'm privileged to get to speak there again this year. But that's my AR Systems hat. For today, I want you to take that hat off and put on your Patient Financial Navigator hat. What I'm going to walk you through with today is what we've been having the privilege of doing is sharing with the hospitals and using what we're doing here in Idaho as an example and sharing with you exactly how you too can be a leader in your community by transforming the hassle factor in healthcare through education. So when we talk about forming a financial navigator program, I'm going to walk you through how we have done it and how we did it through forming of a foundation. So I want you to kind of sit back and say, what are we doing to transform that hassle factor? When you look at what crazy is going on in D.C., and every other day there's words nobody understands, and every other day we hear that another thing is being cut, or what does 340B mean to your public? What did cut in when they're not going to pay the insurance companies the subsidies? How's that going to impact the low-income folks getting insurance through the exchanges? What's an exchange? What's the marketplace? What's the Affordable Care Act? I mean, there are so many words that when you start reaching out to your public as revenue cycle leaders, our job is to translate that. We are probably the only ones who can. Nothing against CFOs, nothing against CEOs, nothing against physicians or attorneys. They never walked a day in your shoes. And when I do, as you probably know, I do a lot of public speaking, and it's a joy, but I'm also a good student. And sometimes I listen to speakers, and I just have to think, you ever worked a day in a hospital? Have you ever tried to explain this to a patient who's traumatized? So let's walk through, and let's start on slide 2. Remember, patients never ask to come to hospitals, except for babies. We kind of set that over there. So when we're talking about the challenges, is our patients come to us when they're traumatized. They come to us when they're scared. They come to us when something has happened in their life. 2 days ago, just to tell you how real this is, I was sitting at a baseball game with my daughter and my grandson, and my daughter gets a phone call that our 17-year-old granddaughter has just been in a car accident. Your gut just falls. I mean, it's like we closed up as fast as we could. We get to the car. We're trying to find out what's going on. Is she okay? Has the ambulance been called? How is she? Can we talk to her? I mean, and all of a sudden, your life is disrupted. Your life is disrupted. Her health will be number one, but, you know, you got the car, too, and the insurance mess. And thank goodness she is okay, that there's, you know, risks and concussions and so forth. But our life got disrupted that fast. It could have been so much more severe. We're so lucky it wasn't. But I'm not sure she agrees, as banged up as she is. But those are the kind of things that healthcare is very personal. When people talk about healthcare at some of these, and sometimes I do, like I tell you, I get a little frustrated when I listen to speakers who never worked a day, never had to talk to a family whose daughter was just given a terminal diagnosis and then try to figure out what their insurance is going to cover. You ever done that? Well, those of us in the revenue cycle, we do it. And we have to be so empathetical, and yet healthcare isn't free. So healthcare is personal, extremely personal. So on slide 3, healthcare is local. I mean, how many of your public know that every insurance company has their own rules for coverage? How many people know that when your poor financial counselor has to say to a patient, well, your Blue Cross will not cover this. We've called for prior authorization. They're not going to cover this surgery. Yes, I know your physician said it's life-saving, but your insurance that your employer picked or you picked will not cover it. They're denying it as experimental. They're denying it as, quote, not medically necessary, which somebody should take those words out of the dictionary, because we use it to, unfortunately, it's a hammer. And then how many of us say that healthcare is truly insurance-directed, not physician-directed? What's value-based? Is that an insurance company determining what's value? Because when you see the results coming in from like United on what they're doing with hips and knees, and their people who are in their network have much better outcomes than the out-of-network. Says who? Says them? And did you ask the patient? Did you ask the facility who didn't get paid the way they should have? But that's value according to the payer. So, I mean, there's so much of this happening, and your poor patient is left trying to figure it out. And if your own employees don't understand it, another opportunity for leadership with education. On slide 4, this is what these slides came from Joe Pfeiffer's presentation a couple years ago, and with his permission, we share this as, and again, this is the class I'm out teaching, so you can use all this material. In fact, I'm going to reference you to a whole bunch of material you can use to set up your own. But people don't know what their insurance is. And then when you go to slide 5, how many people know what these words mean? This is one of my most favorite class. This slide I love to teach to employers in our community boot camps. And I'll say, anybody know what accountable care means? And people like, well, hospitals or healthcare is doing accountable care now. Was it not accountable before? What in the world does that mean to a worker at Chobani's? Well, we're doing value-based care, not volume. What does that mean? Go ahead and ask your own employees what these words mean. A lot of it is really, we're supposed to be trying to get health care under, but the payers are determining what value is. I'm not sure it's the physicians. So lots of conflict. What's a medical home? You even know what it is? So when we do things in healthcare, our patients are confused. And I could say medical home in Idaho may not look like what you're doing in South Dakota. So these are the kind of things when we say you've got to start thinking, how do we translate this for our public? Now on slide 6, I don't know if you saw it, but we have a hospital in, I think it's Missouri, a small hospital that had ransomware yesterday. And they had to shut down immediately. And you don't think the whole area does, I mean, every time we have ransomware and we hear about hospitals at risk, what do you think your patients think about your electronic record? Oh, it's groovy. Ooh, it's wonderful. What is a patient fearful of? That their personal information can get hacked. So what are we doing to help them? And then I love this one too. I wrote an article about this, like what's a portal and who cares? Every time they'll say, you know, you can just go to your portal and find out about it. What is a portal? Go ask an 80-year-old. Do you want to get in your portal? How about a 750 A6? Ask me. When my own hospital changed computer systems, they sent out this notice that said, you're going to have to go this and go to this to get your new portal. And I went, is there a particular reason you're making this as hard as it can possibly be? So your patients are who your information. And now we're going to do, you know, online they can go online and look up their own bills and look up their own estimates. And are you assuming every patient knows how to do this? How often do patients access their health care? Have you looked at the numbers? It's usually once a year, and if you're healthy, it's even less often. So you assume they can get into our stuff and know how to do it all when we have unsecured loans. That's what healthcare bills are, right? They're unsecured. What do? Repossess the baby? We have unsecured loans. How do we get people to pay their bills? We put our arms around them, which is what slide 7 is. As part of my personal mission to pay it forward, I kept trying to figure out as I turned 60 and went, I don't feel like I've given enough back. I was raised with parents who said, You know, what does patriotism mean to us? It means giving back to your country. It isn't, you know, stomp, it isn't beating your chest. It's give back to your country day. I mean, I was doing volunteer work when I was 12. I thought everybody did. You don't even know that that's not what everybody else is doing, because that's the way I was raised. And pay it forward is something that's near and dear to my heart. Well, I had to find it, and we as a community in Idaho, southern Idaho, have formed the foundation. It's an Idaho-based family foundation with a mission. Our mission, and you are part of it, which I'm thrilled Region 8 allowed me to do this, I just couldn't be happier, is to help you know how to transform the hassle factor in healthcare through education for one patient, one family, one employer, and one community at a time. Let me show you how to do it. So on slide 8, this is our board. And the advisory, you don't, of course, remember, I'm not in a hospital anymore. So we did it as an external so we could do it to the country and help the entire country roll out a cool Navigator program with tons of education, with the revenue cycle being the leader and the educator. But if I was in my old hospital, I would be doing it there, and then, but because we're not, of course, you know, I'm not in a hospital anymore. But our foundation, those are all my children and some dear friends who have supported us from the beginning. So on slide 9, what is a Patient Financial Navigator program? Well, what we have done, and what I'm going to teach you now and show you how to do it yourself, I've got all the classes done. I've got all the marketing done. I've got all the articles I'm writing. You can use them yourself. It's all sitting on the website. It's there for you to take and do it. So let me show you how we've been doing it for the last year and a half and give you some things that have worked for us and things that you can probably, again, healthcare is local. So we've created a Navigator program, i.e. foundation for us, and we created it with 3 legs. The outreach community we call boot camps. And those of you that know me, you know that's kind of our branding. We have our AR Systems boot camp 2 weeks from now in LA. We have these boot camps which have no cost, 100% are done by the foundation. So there's 2 different, that's what I'm saying, put the AR Systems hat way over. This is all about no cost. Everything is available for every hospital in the country to use. Every HFMA chapter, you can market it however you want. The goal is to show you how. The second one is employer outreach. I'm going to show you how to do it. And the third one is so cool, a Navigator resource library in your hospital that you can set up. I'm going to show you how to do it. So then on slide 10, these are the three components of your Navigator program. This is not about collecting money. This is not about, we need to get you on the exchange to help you get insurance. That's great, if they even know what the exchange means. Do they know what subsidies mean? Do they know what reduced premiums mean? If they know any of those words, that's great. This is not that. This is 100% education. It's not about, you need to pay your bill. It's, here's what you won't understand. And let me show you all the things that we've done that you can take, already complete, and duplicate yourself. So let's go to our first one on slide 11, are our boot camps. What we've done is our board is we think, and we call it an innovation lab because there's nothing we can't do. There's nothing you guys can't do because you're the educators. You know this best. But when we sat down to try to figure out what kind of boot camps concept we wanted to do, slide 12 is kind of some of our pictures of our boot camp. By the way, that's my husband. And we invite, let me tell you who our faculty is, because we have faculty that we invite in from our community. It's amazing. We get like 200 people on Saturday mornings now. Let me show it to you on slide 13. Let's talk about our community outreach. The top of the list is, this was me. This year I went and visited a bunch of the high schools in the community, and I asked to teach Insurance 101 to their government classes. Now, you want to be humbled. Try teaching 18-year-olds for 40 minutes about Insurance 101 when they could care less what, I mean, they need to learn it, but how did I get them engaged? It was the hardest challenge, I'm going to be honest. So I had to figure out, how could I reach them? Because, you know, so many people criticize our youth for not being responsible. Well, maybe we ought to teach this then. And every time I taught them, I'd say, guys, do you think the doctors who've gone to school for 100 years have any idea of any of the stuff I just taught you? The mass majority do not, because they're like the rest of us. We don't know our insurance until we need it. So I had to teach them things. I'll show you in a minute. What would I get them to engage with me? So I would ask questions like, How many of you want to go out and be entrepreneurs when you graduate? How are you going to get insurance? Oh, and downtown in Twin, where I live, we've got a whole bunch of little shops, and they were talking about the new bicycle shop down there, which has like 6 guys working. It's kind of cool. And I said, I wonder how those 6 guys got insurance. And I wonder if they put in their monthly budget. So we taught them budgeting. Car insurance, how about your body insurance? They looked at me and I went, you do know, I mean, car insurance, you don't have it for some reason. It's legally you have to. But your body insurance, after January, you don't even have to. Why is your car more important than your body? I'll never quite understand that. But we need to teach them to get it in their budget. We taught them pre-existing. I taught them that one because I asked how many people in the room have family with diabetes. I'm not kidding you. Every session had 2/3 of the room raising their hand. I about fainted. How many of you have cancer surviving in your family? Another 2/3 raised their hand. I'm like, holy land, can I teach pre-existing? And what we had prior to the Affordable Care Act and what we have now. And so when it becomes at risk at the, in Congress, these young voters can start understanding what it means instead of just being subject to the change without even being engaged, because they're all going to be voting. So how do we change healthcare in this country if we're not tackling the youngest folks? So it was, I'm going to tell you, I'll do it again this year. This is humbling. So, because I'm not talking to folks like you who know the word. Each positions, I got to figure out what do they think, what do I think they know, and kind of figure out how to present the same way. Then we do our boot camps, and our boot camps we've done 3 a year with 10,000 seniors turning 65 every day now. Remember, the baby boomers are here. Plus, the new Medicare numbers are being issued. They started being issued in June. So we have huge need to do some Medicare 101 education. But at our boot camps, and you'll see this on the website, Medicare 101, Social Security benefits, and assistance for seniors. We usually have 8 faculty. I teach Medicare 101 and Medicare Advantage. Isn't it interesting that I've got to learn that? And then I have an insurance agent help me teach what's being sold in the community for supplemental as well as Medicare Advantage or Part C. And I have to explain the difference. I don't let an insurance agent do it because they're selling. I'm educating. Different focus, but they're my partner, and we do very well with that. Then I end up teaching Social Security because we do these on Saturday mornings 3 times a year for 4 hours. So I teach the basic Social Security benefits with all kinds of handouts. Then we have the Office on Aging teach. Then I have aid for low-income seniors. We discovered that 65% of seniors in nursing homes, Medicaid is paying for that, not Medicare. And people in the room are like, what? I thought Medicare covered nursing homes for skilled, which is maybe 20, 30 days. Then you got to spend down all your resources to get Medicaid to pay. You should watch the room when she teaches. It just goes dead quiet. Nobody has any idea. And so once again, we discovered a void of education on our long-term care coverage. So we're careful with our words. We looked at supplements to help low-income seniors with Medicare Part B premiums. She teaches all that in 20 minutes. And then we have physical fitness, how to keep moving. I've written some articles, and I'll show you in a minute, but I interviewed your physical therapist and your nutrition. Those things come into the boot camps. But one of the things that we teach is motion is lotion. And with my bad knee these days, I remind myself every day, lotion is motion for our joints. And we just sit in our, we have a lot of aged people. We average around 200 people attending. The college lets us use their space. So you need a large space because you'll be amazed when they start coming out and they figure out this excellent education you're doing. You don't talk about anything other than education you don't get to put your own little twist, because people thought they got to trust you. They trust you as the educator. Who else knows this stuff? You do. You put it all together. Think about now when they look at your hospital in Iowa. Think what they think now. Gosh, they're doing free education to help us understand all this Medicare, and I'm about ready to turn 65. I don't even know what's going to happen. Oh, we have a dedicated boot camp just for that. And now we add people that help them set up budgets for when they're going to turn 65. What if you're still working? I teach Medicare secondary payer. They don't even know that exists. We expect our patients to understand what you and I live with. So after 38 years, I'm like, wow. and they come out of the woodwork once they start understanding that you're there to teach. You're not going to ask about money. You're not going to tell them, you know, you're going to teach, and you're going to help them make good decisions. It's amazing how they come out. And then we start, let's look at slide 14. Then we start working with the small business folks. So now I'm going to work with some employers. And we do boot camps. We call them all-employer healthcare summits. We do 2 a year, 1 in the evening and 1 at lunch. And I teach what does disruptions in healthcare look like, which, by the way, is on our website. You can go get it. We have the hospital teach what's hot in healthcare. So we're teaching what's going on, and then we have the hospital administrator talk to all the employers. Anybody's welcome. Anybody's welcome. And once again, you're leading the effort with education. Maybe there's something very hot that just happened in your state. Minnesota, something's cooking there, and you would like your public to understand it. You put it on the agenda. I've invited the legislators. They're chicken to come sometimes, very honestly, but at our Insurance 201 summit we had every representative of all of our legislators take Q&A from us. Well, you know, they're a little scared of it because everything's a little hostile, but I went, you know, you need to understand the number one issue when people are doing surveys is healthcare. The number one issue of concern is healthcare. So bring in your legislators, bring in your hospital leaders, but the revenue cycle, you sponsor, work with your small business. Do you have a Chamber of Commerce? We went out to Chamber of Commerce. They supported. They come. Think of all the cool things you can start teaching when that's what your Patient Financial Navigator program is about. So on slide 15, part of the outreach, this is what I'm writing, and again, all my articles are out on our website. Go get them. You put your name on them. I don't care. Play with them. You're welcome to them. There should be about 20 different articles I write for our local papers, and it's called Healthcare Buzz. And like we talk about scams, we talk about safety in the home, I talk about the new Medicare number, I talk about Medicare secondary payer, out of network. It's just everything that you think your patients know that none of them do. And yes, what is the number one thing? We don't know about our insurance until we need it. This is your way to say to your public, I know that's when most of us do it, but would you like to know about it ongoing? And I have people that will see me in the store now, and I guess they include a picture now, which I wasn't including my picture, but I guess they are now. And they come up to me and they'll just start talking to me. And it's so cool because I have no idea who they are, but they may have been at our boot camps, and we've had 5 now, and or they may have been reading the article, and mostly they just want to feel connected. And think if you're the hospital doing that, will the patients pay their bills better? One of the things that I'm hearing is, and I do see this, is with all the consolidations that we've lost a lot of the personal contact in our hospitals, which brings me to the third leg is your Navigator library, so hold that thought. And then on slide 16 is just a copy of one of the articles that I've written. I guess I'm the one writing these. So again, all that on our website. Go get them. They're yours. And then on slide 17, more outreach. You all have health fairs. I bet every hospital in the country does some type of a health fair. Why don't you have a booth? And what we call it is Ask the Expert booth. And so you have your Patient Financial Navigator program. Bring us your insurance questions. Bring us your EOBs. Bring us your monthly statements. And we have a little divider, and my people and myself mostly, but I also have 2 other people that help me actually from the Office on Aging. They do a great job, and they partner with me a lot. So they're learning from me, and I'm learning from them what they're getting asked a lot with the senior centers. And they have national exposure to some information differently than I do. And so think about how you can be the translator of these crazy words. Not healthcare, not patient care, everything else that impacts our patient. So then put on your employer hat, slide 18. Okay, second leg is employer now. You already kind of heard how we did some of these big employer summits in our communities. But then we reach out all the time and we say to the individual employer, would you like us to come? And what a lot of your employers are doing is called wellness. So they have wellness that they offer to their employees. Well, I go to they have a 30-minute program, and I tell you what people are asking. They're asking how to read their EOBs, and they're asking what out-of-network really looks like. So I teach really, now after having done it for a year, I teach those two things most of the time. But then on slide 19, this is kind of my employer class here, I always teach what's going on in the background. Because, you know, most patients have no idea that you're calling their insurance for authorization, that you're going to have estimated charges. It's only an estimate. They're going to get bills from all these different people. And then I say, well, how about slide 20? This is how I taught the seniors. I took carpal tunnel. You know, by the way, I had an orthopedic surgeon tell me, I want you to tell everybody you teach that they're going to kill their thumbs. If they don't, they're going to all have massive problems with their thumbs because of the phone, but they're also hurting their neck because we're leaning over all the time looking at our phones. So they need to sit up and pull their phone up. So at least they're not killing their neck, but they're also killing their thumbs. So I said, hey, how about we talk about carpal tunnel? So I explained to them how carpal tunnel bill is going to work. And they're going to get bills from the surgeon and the hospital and the anesthesiologist. And if they have any pre-op testing, and if they had a sample taken, maybe they had a cyst, then they'll have a pathologist report. You're going to get a bill from all those people, and they're all separate. And they kind of look at you like, you've got to be kidding. I thought it was just a hospital. When you start making it real, people get it. And then on slide 21, this was one of these employers I did, and they had Cigna insurance, and you'll see one column is out of network, one column's in. So what a great opportunity to teach them how to read their columns. But here's what you also teach. It's called balance billing. One thing we forget to mention in out of network, when a hospital, if you look to the next slide, 22, this is an in network. So I showed them their EOB, and I'll say this column where it says the amount you absorbed, that amount will not be present in an out of network. And many hospital doctors are making the patient pay that amount. So instead of having the covered amount and the amount you absorb and then down to the amount the patient pays, that's in network. Out of network is they pay that, many hospitals are requiring the patient to pay that middle amount. So essentially they're paying full bill charges. That is a hidden goodie that most people don't know, and unfortunately there's a story in the class that I was involved with, and I learned firsthand doctors, labs, everybody expects full bill charges because you're out of network. You don't have a contract. So this becomes hugely important that you educate your public. It isn't just 2 deductibles because it shows that you'll pay more per visit and you have a second deductible. Oh man, you got balanced billing here. That no insurance agent would even know how to teach that. Oh, you do. And when you get their EOBs, you show them that. Then on slide 23, I threw in another EOB just so you can start. This was just a simple test. But in network, what the patient would owe, and then out of network, you show the amount that your discounted rate, you would owe that. Plus, so full bill charges end up being the issue if you're out of network most of the time. So then I put in slide 24 because I thought, man, these people, this is huge. They don't understand this. And I'm not sure hospital staff understand how deadly it is to be out of network. And they have to, and there is a way that we should be teaching our public that they could request to reach out early and ask that insurance plan, the out of network, and talk to the insurance company and request an exception, but be very clear because balance billing would be up to the hospital you're going to. Your insurance can say, okay, we won't charge you a second deductible, okay, but will ABC Hospital acknowledge the in-contract rate versus out-of-contract rate? You're going to get slammed there too. So I think our job to teach out-of-network is and I'm not sure everybody understands it. So slide 26, I think I put a slide in there twice. This is just an example of a real example, the one I got involved with, and they asked me to help them appeal it, and it was an undertaking. Oh, man, if this wasn't somebody I knew, I wouldn't have probably done this because it was massive. But this is a true story. This person had, remember, employer insurance. They had 3 surgeries. Their ankle collapsed, big surgery to rebuild so he could walk. Very young man. On the 4th or 5th surgery, which surgery I'm up to, the 4th surgery, over this 8-year period, the insurance changed with the employer. So we have 3 surgeries in network to go to the same surgeon to do the 4th surgery to try to make it so he can walk. They had to put in titanium rods in his ankle. I mean, we're talking huge stuff here because he had his whole arch in the bottom of his foot collapsed. So he's out of network. And they were told they were out of network, but he didn't understand balance billing. Nobody told him they could call ahead of time and ask not to be granted the exception because, of course, the insurance said, just go to the doctor in network. And I had to involve the surgeon to say, would you ever touch this patient who's had 3 massive surgeries by a different surgeon, and now a brand new orthopedic surgeon is going to step in and do the last surgery to put in the titanium? Really? And there wasn't, I had to get doctors, I had to get them to write letters, we had to try to get the insurance company to understand that is not good patient care on your best day. Then we had to file for financial hardship with all the hospitals and the doctors and all the labs because they took full bill charges. So this happens. People change insurance plans right in the middle of course of treatment. You can be in network and then move to out of network. Hospitals, don't let that happen to your patients. The last one I want to talk to you about is, to me, the pearl. So after you've been doing your boot camps and you're out meeting with employers and you're teaching, and you're writing articles, and like I said, the boot camps are quite simple once you create one. And again, go get the materials already done for you. You just have to update it. Then I want you to think about creating a database. Now we call it a resource library, a Navigator resource library, where you can have a glossary of terms. You can have, and you could have, I'm going to use Chobani's because you all know Chobani's. We have the largest plant in the country now, sitting in the world, by the way, sitting in Twin Falls, Idaho. So we have like 2,000 employees that work for them. And what do you think they don't understand their insurance? Just guessing. So what if one of those patients ends up in your ER and they're traumatized and they're scared? Who's going to teach them their insurance? So what we would, and this is very much specific to your community, go to your employers, get their benefit packages, the work comp and the medical, build a database. Now every single patient will know. And think about what you can say to your patients. Oh, it's okay, ma'am. It's okay. I'm so sorry this has happened to you. We're here to help you understand, to reduce your financial surprises. Here is all about the Chobani's insurance plan. With their permission, this is their plan. Now, of course, I did this 20 years ago in my old hospital, by the way, and we did it a whole lot less automated than it is now, and we had workers' comp. My registration supervisor would call every large employer or mid-sized employer in the area. We would get their workers' comp plan and when it renewed. We would get their medical coverage and when it renewed. And then she would call them again, and then we became partners with all these human resource departments and all these employers. They would call us so that their patients their employees were not adversely impacted. Instead of the hospital being the bill collector, the hospital became the educator. I did it 20 years ago. You can do this. And it does, I hope to be able to have this operating in my own hospital since I volunteered to run it 2 days a week. And I have the volunteers at the hospital ready to be trained, and they have to provide 1 FTE to staff it. So maybe we'll get that done, but it's a very automated process now. Think about what you give your patients. And by the way, do you think they pay their bill now? Because you put your arms around them. They know you care about the financial surprise they just got hit with. They don't understand the words. You've got a glossary of terms. You can hand it to them. You can print off their insurance package and teach them what the words mean. And then you now say, here's an estimate of what this is going to be. Here's our payment plans. Can we help set something up for you? But you educate first because you don't know that plan. Your staff certainly doesn't know that plan by heart, and that patient needs us to help them. So slide 28 is just an example. This has happened to me. You know, like I said to you, it's the first thing I try to do, especially for family and loved ones, is ask, do they need help? You know, my daughter, my granddaughter, the first thing I started teaching was med pay out of her medical insurance from her liability plans. And now what about your insurance with your medical? And tried to guide the family what to ask. But wouldn't it be cool if the hospital had that right there and handed them the work paper? You were in a car accident. Okay, here's some of the things you need to be doing. Here, boom. This is going to help you with the financial surprises. And then, of course, slide 29, how many Medicare patients understand Part C versus traditional when they need it? Again, great great program for the resource library to do. And by the way, you might ask your volunteers. They're one of the ones who are the strongest saying, please get us this Navigator library. Because, you know, the patients come to them. They come to the volunteers. They don't feel threatened by them. And they're always the ones telling me different stories of what's happened. You know, I get phone calls. I don't mind them. I had a phone call from a previous employee. No, it's the person I worked with. It was another department head, long retired, and his wife got a very serious hospitalization, and he got a bill for $300,000. And he went to church, and the church was asking for donations, and how are they going to help him pay his medical bills so he can keep his house? And I went, how old is his wife? 72. I said, she doesn't owe $300,000. He's going to owe $1,600, his inpatient deductible. No, they told him that was what it was going to cost him. I said, never. He has Medicare. Why do we do this to our families? And he called me, and I walked through. I said, get something to write on. Here's what you need to do. Now, why didn't the hospital do that? It's inexcusable they did that to that family. But the only reason I got called is somebody at church knew that. He says, I don't think that's right. Why don't we call the Navigator Foundation, which in your place, why don't they call the Navigator program and make sure your number's well known, and you give them the right information. This is what your itemized bill is, but you're not going to owe that. You have traditional Medicare. You have the inpatient deductible. That's it. Now, I'm about ready to take some questions, but there's a couple more slides I want to cover with you. I always teach the Affordable Care Act now. Why? Because people don't understand it. It's been 7-8 years. We have a tendency to have short-term memories. One of the things that we have to remember is that the mandate only impacted 50 employees or more. 92% of every employer in this country has less than 50 employees. So the mandate to have insurance impacted 8% of the employers. But there's still a ton of people. But if you just look at pure volume. So what we try to do is, in our employer summits especially, is help our people in the community understand that the exchange or the marketplace, in my state it's called My Idaho, we teach people how to go out there and apply. If you're 3 employees in your little entrepreneurial welding shop, go to the My Idaho and look to see if you can get some help, because your income is going to be low, you're a startup company, you're just dreaming the dream, and you need insurance. And if we lose the exchanges, all of those 92% under 50 are not going to have a real opportunity because the premiums are astronomically high. Which brings me to slide 31, which is where the data comes from. I always try to teach that people understand we have a massive amount of small businesses in this country. 92% are small businesses. How are they getting their insurance? Especially if you look at slide 32, this is my story. I tell the country my story because I think you need to understand that there's an awful lot of entrepreneurs out there dreaming the dream. How are they getting insurance? Look to the exchanges. Now, personally, I don't qualify for any subsidies, and I shouldn't. I'm not low income, but we have friends, my nephew, who was born with a disability, not enough that he's disabled, a very proud young man, but he's never been able to afford insurance. My brother, an attorney, said to me with the Affordable Care Act, and he just reached, I didn't even think about Dane, and he goes, do you think he could qualify for some help with premiums? Because he's always just been like a hardworking kid, but grocery store clerking and maintenance crews. And I said, oh, my land, he doesn't have insurance? He goes, he's never been able to afford it, so he has none. I said, oh, please go on the exchange. And my brother calls me, and he goes, for the first time, my son has insurance because he's getting help with his premiums through the subsidies. Now, that's a short version. There's other words, but that's the shortest way to teach it. So I kind of feel good in my heart. We have a friend who's an electrician who has heart condition and has had to break. He's a single entrepreneur electrician, skilled, very skilled, but his heart condition has now made it so he has trouble working full time. So we said to him, how are you getting insurance? He said, I can't afford it. I'm going without. And I said, no, you're not. Get on the exchange. Your income has dropped so much, you might qualify for a little help with your premiums so you can get some coverage. He is getting insurance now. We have to teach that because it's all about small employers as well as individuals. So my premium is $1,200 a month for my husband and I. We are both in a high deductible plan at $7,200 each with a 70/30. And turning 60, any of you who haven't yet, and you're a small employer under 50, you will be age rated. So my premiums every year for about the last 6 years has gone up 25%. This year it only went up 13%, and I was supposed to be happy. So this isn't sustainable. It's $15,000 a year just in premiums for just two of us. So I'm all about exploring alternatives because I don't know how many of us can continue to pay that. Then on slide 33, these are the 10 essential benefits. So when you hear people say, you know, we want to offer insurance that doesn't offer these benefits, do you know what that means? Do you remember the days of the cafeteria plans where you could pick and choose what you want? And I explained this to my seniors, the senior high school. And I explained to them, childbearing is a big deal, maternity and newborn care. Why am I paying for that? Because the idea, now of course it didn't happen because insurance companies didn't do what we thought they were going to do, and Congress didn't make them. But remember when it was originally created, everybody was supposed to have insurance. We were all supposed to share in the cost of all of the benefits so that a maternity age mom and husband didn't have massive premiums while mine was really low because I'm not maternity anymore. That was the vision, but didn't happen because we never enforced the rest of it. And you can all have your own opinion about it, but that's what they're talking about with that piece. Then on slide 34, pre-existing. You need to be sure people understand what it was like before the Affordable Care Act and since, because that's always on the cutting block again. In fact, it's in the budget that pre-existing, they're going to cut Medicare and Medicaid funding, and pre-existing is taken away. So all the protection that we've had, you need to be sure your public understands what that looks like. Lifetime benefits. Remember, prior to the Affordable Care Act, they used to have lifetime benefits like on cancer. Now they can't. They have to keep paying. So you can imagine insurance companies are not wild about this one, or the other, or the kids that can be on until they're 26. And do you know you can be married and still have coverage? I'm like, all the kids going to college, their parents can keep them on their plan until they're 26. So amazing. This is part of some of the stuff that we always hear lots of discussion. I'm just not sure and I teach this all the time. I want them to know what the words mean when they hear about it coming in from Congress. And then last but not least, I'm about ready for questions. I always try to teach on slide 35, ER is not the place for health care. And people don't have a good understanding of what they can expect for a bill when they walk in the ER. In my class out on the AR Systems website, and by the way, the PFNF website and AR Systems website, they're linked, so you can pop back and forth, because under AR Systems class, we have about 15 classes you can get. Under Patient Financial Navigator, all of these classes are there in the classes we taught for the small employer All Summit for all of our boot camps. So one of the classes we try to teach is this disruption in healthcare to help people understand the insurance companies are now starting to discontinue paying for ER visits or paying such a very low amount. And I'm going to be teaching that class, by the way, at Region 8 in August. So when I'm trying to teach anybody what goes on in, the frustration our ER doctors have that the ER is a quasi-doctor's office, I get that, but look at who's in there. 50% of our patients in our ERs have Medicaid, because Medicaid physicians aren't taking Medicaid patients because the payment's so low. So where are they going to go for care? The most expensive place in town. So hospitals, I hope you're getting creative at creating lots of urgent care centers instead of your ER, that you don't charge ER visits when you are the only place that's taking Medicaid, or like even Medicare these days. My in-laws are like, well, it took us 3 months to get a doctor. Yeah, well, you got Medicare, you guys. Well, I can't believe it takes that long. Jeez. I said, that's called access of care. You have insurance. It's just too bad it's Medicare because they pay low. Medicaid pays even worse than that. So we have all of our uninsured patients, not all, a huge percentage of the uninsured are going to the ER. So what are we seeing in national data? As the mandate is no longer required in January, the penalty, where do you think those patients are all going to keep their insurance? We've already seen an increase in the uninsured. They expect it's just going to keep going up. Where are all those patients going to get health care? The most expensive place in town. So I try to scare people away. I'll say ER is not where you go, guys. You can't afford a $3,000 bill. Get a primary care doc. Get to the urgent care center. Go there, not the ER. It's not made for non-emergent care. So it's my opportunity to try to educate people on how expensive it is. But on the other hand, if hospitals only have an ER, guess where they're going? So can you explore another alternative? Because I'm afraid this is probably what we're going to see more of, not less. So last but not least, page 36. There's the website, pfnfinc.com. On that website is all the classes from the boot camps, all the articles I've written. There's a bunch of stuff there from Social Security, good education classes from them. We have, we post anything that could be helpful that, that I become aware of, but mostly it's all the classes so that you could host your own Medicare 101 boot camp. You can host your own employer summit. You can host your own Navigator library because it shows you how to do it. So we hope that through these kind of free webinars that we can continue to encourage you. Now, last but not least, if any of the hospitals on this call are interested in discussing, or you have your own ideas, or you say, I would love to do this, but could you talk to me privately about how we can get going? Happy to do it. Just let me know. We can set up a call, and I can get you going. I can tell you from having done the boot camps and the employer outreach, I'm speaking at the Rotary Club on disruptions in healthcare in about 1 hour from now, because everybody wants to understand it, and it's our job to simplify it, what I call transforming the hassle factor through education. So I hope this was inspiring a little bit to you, and that you can see how simply you can put any of this in place in your own organization, in your own community. So Nikki, are there any questions out there that I need to take in these last few minutes together?
Yeah, I think some have come through. I tell you, Day, your passion just comes through loud and clear on these calls. I love it. Before I take our first question, I just want to remind everyone real quickly to just to submit your questions, just type them into that questions panel located to the right of your screen, and we will read those aloud for Day. I will go ahead and address one question about accessing the replay. Got a few of those. So we will make sure that this is distributed to everyone on the call. It has been recorded, so no worries if you'd like to listen to it again or share it with some of your other colleagues. All right, one of the questions came through, and please chime in if I'm messing this up a little bit, but it sounds like when you spoke about the communication, the community outreach, there was one particular attendee who had a question about if there's a difference in how you execute on that in an emergency department versus a non-emergency department. So is there any insight there? And I guess maybe, yeah, I'll leave it at that and see if that makes sense.
Well, I want to be sure I understood. Is she like how I would teach that?
I think in terms of do they, and she's jumped off the call. She sent me a note saying that she did have to run, but she was really hoping to find out if they do a community outreach, should those two departments do it combined? Should they do it as a joint effort?
Well, if you want them to participate, the only thing is you got to get really good trainers. So every time when I went looking for faculty to co-teach with me as the revenue cycle leader, you always want to figure out what the message is. So if you're trying to teach the urgent care versus the ER as one of your topics in your boot camp, you could certainly have them show some statistics. This is the ER, and this is how urgent care could help you. So you're educating the public on the choices and the cost. Still good patient care, but the cost is much different. And how they can access an alternative instead of the very expensive ER. So if you add that to your agenda as one of your topics for your ongoing boot camps, you could certainly do it that way.
Perfect. And in addition to the in-person events that you mentioned, would you suggest hosting something like this as an online event?
Well, I think you have to remember who your audience is. With the boot camps that we're doing right now, where, again, Medicare 101, 65-year-olds, no. I would not do it that way. I would think you have so much to teach. A lot of times they are a little intimidated anyway because they feel stupid. Nobody wants to feel stupid. They feel stupid. So we try hard to engage them, and I have found that face-to-face with that group. Now, the employer summits, you probably have some alternatives you could do with that group because everybody records these. And again, the Chamber of Commerce does, and we have the hospital has sponsored recording of the employer summits, and they've made it available on their portal, their website for people to go see. But again, younger group, a little more engaging, they would probably not be intimidated, where I'm afraid the Medicare group, you're probably going to need face-to-face. Depends on the audience.
Yeah, no, that is an excellent point. All right, so I am going to just tap dance just a little bit in case any other questions come in. But in the meanwhile, I would like to at least thank our members in the healthcare community at large for joining this call. When we exit, you will be prompted with a survey, and we would greatly appreciate you sharing your feedback about today's event as well as other topics that you are looking for in the future. Day is kind enough to leave her information up there on the slide, so you do have direct contact with Day, as she mentioned, if you'd like to take advantage of some of those programs and get some guidance in that area. All right, so no other questions have come in at this time. So again, thank you, Day. As always, a pleasure working with you on hosting these educational events. We appreciate that.
Absolutely, and I look forward to seeing a whole bunch of you at Region 8. And you have, again, send me an email if you have any questions, if you have any observations, ideas, because I love to hear what other folks are doing, that I can share the good word. People like to know that they're not alone with some of their challenges. On the other hand, if you've had success stories, love to hear those too. But please feel free to use whatever can help you out on that website.
Awesome, thank you. And on behalf of HFMA Region 8 chapters, thank you again for joining. Have a great afternoon, everyone.
Thanks, guys. Bye-bye.